of movement in an individual joint. So we would do this. And then perhaps we find down to one joint. And this is when, after this, we could consider the various manipulations that we could do. And they're all going to be variations on the distraction or rotation or posterior glide theme. I'll ask, in fact, I'll get Chris to just stay where he is. And the first of the techniques is the technique that was developed by Kaltenborn, which is called, in German circles, the Doppel-Nelson, all right? And in this particular case, with Chris, we are going to ask him to put his hands round the back of his neck, and he interlocks his fingers, and he takes the contact as near as you can. I mean, and the further down you get, it's quite good for the T1-2. Any lower than that, I think we've got to use a slightly different technique and probably a wedge technique. But at the top part of the neck, this is not bad. It would be impossible and stupid for somebody like Bob to be trying to do this on Chris. It just would be so pointless that, you know, it's ridiculous. So she would use the mobilizing and not try and do this one. But if she was working on someone like Suzanne, she probably could do this all right. But you don't sort of try and do it when it's totally unreasonable, your size and their size. You try and get this on one of your colleagues' lists, so you're not killing yourself all the time. So what the technique will be here will be this. I'm going to sort of come around through the arms like that, and try and take hold of the low joint upper aspects of the segment so that I can do a little distractive movement in a cephalic direction. So if we're dealing with T1, T2, Chris probably gets down to about C7. I come through and thread onto T1, and then hopefully by getting all of the lines correct, I shall be producing I'll just get him to put his arms, just relax them for a second, a cephalic glide of the facet joints and a distractive release of the disc. That's what will go on. And I'm trying to hang him from the contact point around his neck so that when I give a little impulse, this is kept stable by the weight of the lower segment. The cephalic part of the caudal part of the segment is just kept still by the weight of it and all the rest here. And so we give this little impulse. What we have to make sure is, and this will be when we use our knees to do a slightly different technique but with the same intention, what's important is that we keep the arms in a slightly forward position like that. We don't let them prise back into this position. That's what's quite wrong, and you see this all the time in books. Not of this particular technique, but certainly when we use the knee technique on T3, T4. And so we try and keep the arms slightly forward so that when I lift, this will come up in this direction, and I won't be doing that. And the other thing that very often happens with this that you should try and avoid very much so is that by coming around here you end up doing that, which is an acute flexion technique. Forget it. That's not what this is about. It's about these facets like this, the disc like that. This happens, that happens. That's what we're going to try and achieve. Now, it's very nice with these tables to take them up. You've got to have these tables fairly high, or any table you're using. These are fine for doing this on. And I'm going to ask Chris to put his hands around his neck. I'll come around here with my thumbs or with my fingers. I'll try and get onto here. Just take your arms forward a little bit. Don't pull them forward, but use a little bit of sort of just the tone in the arms. And I'm just going to come back and lift straight up in the air like that. And that will be the procedure, to just underneath and just lift up in the air.
Why don't you want the table lower?
Because the chances are then that if it's lower, you'll tend to bend it forward. If you can get right down and push up like this, looking towards heaven, you might get some help. Okay? And you need it for this technique. Kaltenborn is a big man. He's got big hands. And for him, this is a very successful technique. I found this relatively successful with most patients that I do this on too. Chris, I didn't get a release there, and we're going to have to do a different technique on him, because I won't be beaten.
His fingers are on.
I felt too.
Oh, did you feel it?
Yeah.
Oh, all right. Success. I'm just thinking about my poor old thumb. So there we are. Good.
If his fingers are on C7 and yours are on T1, you're producing this distraction at T1.
2, yes, yeah. If he could get down to T1, that would be great, and I could get over the back of him, but the chances are that it's going to be more and more of a strain as he comes down. So I just really ask him to support really the cervical spine, and we're going down to T1, perhaps T2 if possible, and then from T3 up to T2 or T3-4, we can use a slightly different technique with stabilization here with our knees or with a wedge. So we can kind of get just in this difficult area with this double Nelson thing.
Did you have him lean back? I couldn't.
Yes, yeah. So let me just demonstrate that one again. Goes behind the neck. I thread through here. I ask him just to take his hands a little bit forward. You just, or your elbows just a bit forward, like this. I just let him come back here, and I'm trying to keep him in this position so that the disc is kept horizontal to the ground. Let it be just a little bit of a move up like that. And that's how I'm trying to achieve this technique. I don't want to prise his arms back. I don't want to take his head forward like this. That's all faults of technique that we must avoid.
Now you're using your index finger, is that because you don't want to use your thumb? Or
You can use whatever you like. I tend to actually use my index finger, but that would be fine. You could use your thumb, whatever is the best for you. The only ones that I don't bother with this technique is, and it's usually with women, I must say, and it's not very many, but sometimes, you know, you put your hands behind there, you give this description. Now, I want you to take your arms forward, and they go forward a little bit, and then you say, now, I just want you to keep the tone of them. And you do this, and their arms fly back. So you tell them again, and it's as if you're dealing with spaghetti. A couple of times of just testing it. If that's the case, I go to another technique. It's just frustrating. The other thing you have to watch are men who you say, now, I just want you to take your arms forward, and they take them forward, bang, like, and you're being all like pulled over their shoulder. And then you say, no, no, not like that. I just want you to kind of like the tone in your arms, no strength. They're a useless group to do it on too. So there's the spaghetti type, and there's the ones that really pull forward like this and don't have a concept of just leaving the arms kind of like firmish, but not pulled under major control. So, you know, it's one of these techniques not to frustrate yourself with. If it works well, but sometimes there are patients who just don't seem to catch what you're trying to do. And we've got other things, so this is just one of the things that we can do here. So, first technique to try, double Nelson. Remember the points about it and see how you go on. Don't hurt your backs with this, though.
I've had to do with this technique. One, to protect my own back because I cannot thrust from extended position.
Ma'am, could you stand over here so it could be picked up on the mic?
Oh, sorry. I forget I'm the source of sound here. Okay.
I have to get the table lower so that my thrust comes out of my knees rather than from this position, extended position. The other modification I have to make very frequently, if the patient puts their both hands on and then I come around, I cannot reach to get the interlock. So what I found I frequently do is put one hand on first and then ask the patient to interlock their fingers over my hand. That also helps for them to get in the right place. And then I can come on from here. And I can come on from here. The next thing I ask the patient to do is arch their low back, so that as I bring them back from this relatively low position, there's no chance of me getting into cervical flexion. So I get them to arch their low back, no more, and then say, come back towards me, and then here, I'm in my position to come up from here.
Good.
So the thrust is from your legs?
That's right.
Yep.
And hands, but I'm in a position where I can get my own back into a neutral, slightly flexed position
And you maintain
rather
the
than from here.
lordosis just so you don't flex them excessively?
Yeah, because otherwise, if they're flexed, then you say come back. Typically, then I find the patient does and goes into a forward head slump when they're back here. If you get them to arch and then come back, then the head position usually stays where it is supposed to. The other thing I find by getting this hand on, I can get on some of the, not the very spaghetti people, but some of the looser shoulders, then I can get a link here tight in onto their thorax. And that helps me to get some stability through the shoulder girdle.
Thanks, Anne. Perhaps try that one, just to see if that, with that interlinking, the table down a bit, arch the patient's back, hang them still from the cervicothoracic junction and then lift up. See if that's more successful for you. Although people seem to be doing this quite well. Okay, I'll get Chris to lay down on his back here. And these are some of the techniques that you would have done with Diane, because they're their sort of standard manual therapy techniques. When we talk about the segment, of course, we can do a variety of things to it. We can distract it, which we've just done. We can rotate it, and we can do a variety of things. Now, I'm going to sort of leave that description a little bit to a little later on when we do the thoracic spine in terms of all its manifestations. But just so that we have got some lead into that, one of the techniques that is quite useful, of course, in this area is a technique where we are going to distract against a wedge or distract against our hands. And the kind of classical position for us to use will be the position of creating the hand tripod, like this, so that we can engage the facet joints, or sorry, the transverse processes on our middle finger. The space that we create by our index finger being extended accommodates the spinous process, and the thenar eminence accommodates the other transverse process. Now, we know that if we put our hands in a position where we are accommodating different transverse processes and contacting them, then we will produce a rotation. If we have the same transverse process, depending upon whether our thrust is in a longitudinal direction, would produce glide at the facet joints, distraction at the disc. On the other hand, if we then take it at right angles to the facet joints, it's going to produce a translation at the disc, but a gapping of the facet joints. Now, in this area where discal problems are less common, and probably fairly rare, certainly below T2, then probably the posterior gliding technique will be one of our favorite techniques because it has a bilateral gapping effect on the facet joints. So, there are a variety of these that we can do. And let me just demonstrate one or two so we can practice them, and then we'll spend a little bit more time with these in the rest of the thoracic spine, and that'll refine what we're doing at the top here in all its manifestations. Now, with Chris, there are two positions that I would use the hands in here. I tend to use this position quite a lot, because I find that I can give more of a distraction when I've got the arms here than when I've got the hands behind the neck. Now, Chris might be a good example of when not to use the hands behind the neck anyway. Could you put your hands behind your neck, Chris? Because it may be that I would find a great deal of difficulty of getting his hands low enough down without hyperflexing his neck because of the tone and the stiffness in the shoulders and the muscle mass that he has here. Okay? Now, with Suzanne, who's not quite so muscled, of course, she lays on her back and puts her hands behind her neck, and I bring her arms down, it's much easier for me to get them down. So in Chris's case, I would probably tend to use this. In Suzanne's case, I would probably use this because I prefer to, but I could also have the arms in that position as well. But with many men, you sort of say to them, now put your hands behind your head, and their arms are stuck up here, and they're totally out of anywhere that you can use them, because you want them down over the chest. However, like this. But stuck up here is not really a feasible lever for us to use. Thanks, Simpson. So here we go with Chris. Now, Here's a little mnemonic. I've got lots of little mnemonics in this area, in the sense that sometimes you get lost where you are when you've got the patient turned around and you're not quite sure what you're doing. But as far as the arms are concerned, get the arm that's nearest to you to be nearest to the patient. That's got a lot of advantages. Rather than have it like this and have a space on this side, we want it reversed. So it's close to Chris. The one that's closest to me goes closest to him, and the other one goes across the top. And it means I'll be able to get closer to him than if it's over the top like this, and I'm trying to get right over the top here. It's got some other advantages when we start talking about rib techniques as well. So I shall be in this position, and his arms will be down there. Now, I'm going to ask him to bend this knee, and I'm going to just simply, come down the bed a bit, Chris, so that you're on, that sort of tough bit here, and come over just a little bit there. Put your hands back into this position, and I'll just ask him to allow me to roll his whole body a little towards me. I don't want him adjusting his position, because when he rolls back onto his back, I want him in exactly this position. So I'm going to sort of look at T1, T2, T3, those areas. So I would come around here, and at this position I can gently have a look at the motion again. Identify the level. If it's at T1, 2, we'll be on the transverse process, which is 1 finger's width below the spinous process at that level. So I engage the spinous process with my hand tripod in that fashion. So then I put Chris round like this, hands over there, into that position. Now I'm in a position to either distract him, which the joint released, or I'll take another one here, or to push it backwards. There. 2 for 1 there. So here we get a distraction one first, which was that way, or I can go into a posterior glide, which is this. Exactly the same technique, just a slight difference in the emphasis of my direction.
You said you engage the spinous process?
No, engage the transverse. Let me just show that so that we'll... So I've round here, this transverse, that transverse, there and there. And the spinous process accommodates into the space that's been created by my index finger. Now, this is interesting. I have never ever had any problems with my middle finger. A lot of my colleagues have a lot of problems, and so you have to kind of create some little pad or something, perhaps a rolled up paper towel or something that you can put in just under your fingers there so that it supports this joint. I've never had any problems, and I don't know why I don't and they do. Perhaps that's why I've got in my thumbs. Okay, pulling this back too far, who knows. But that's the sort of contact. But try and protect your fingers with these techniques. Yes, Don.
This technique of how high?
I think you can get up probably to, possibly to T2, T1, possibly. T2, T3, no problem. But C7, T1, T1, T2 are difficult. That's why I tend to use this one a lot, because I feel that most people I can do that on. And we've got 1 or 2 other techniques that we can do at T1, T2, but they all involve a little bit of rotation. It's a difficult area because of the length of the lever and the difficulty of accessing it. That's why Kaltenborn's technique is such a good technique.
Could you show the distraction?
Yeah.
What's giving the distraction, your upper hand?
Both. I'm trying to resolve the forces again this way. So, and this is of course a reason why I need to have my other hand around and not taking hold of the arm position. So I would come around. The first thing that I do, as you'll notice with Chris, is to roll him off my hand, largely because I don't want him weight-bearing on my hand all the time. And then when I roll him back, I maintain the little neutrality of the thoracic curve. That's very important. The lower down we get, it's even more important that we maintain that slight kyphus. So as he goes back like this, I support that. I do not let him drop over me, just drop over Chris, but come off if it hurts too much. As he goes down here, this becomes quite uncomfortable. And the lower down he gets, it's very uncomfortable for the patient. So try and maintain that thoracic kyphus there. Now, the technique for distraction would be that. I'm just pushing there, and I'm pulling there. So it's going to be that movement there. And the backward glide would be to come up a little bit there and push down through there. Supporting all the time, though, the cephalic lever. So it doesn't just drop over your hands. All right? So let's try the distraction and the posterior glide at the thoracocervical junction. Okay?
Through the elbows primarily for the glide, and through your hands for the distraction?
No, I'm doing both, actually, Bill. With the posterior glide, I'm coming in that direction. With the distraction, I'm coming more in that direction with a resolution through my hand.
So it's through the elbows where the impulse occurs?
Yes, through both cases. So I think with the women, you probably need to put some padding here because you shouldn't have people's elbows in your breasts, of course. So that will be a thing. And I don't know, Anne might have some modifications of this that she does. Or do you just use a pad, or?
I use a pad if I'm going to use that, or I make sure that the end of the table is
Up a little bit.
the pillow on it, so
Yeah.
I can work through.
Yeah. So, yeah, that's a good idea. Just to pull up in this position here. It's much more important, certainly when we get really low down, that we use the tables right up. I've not done that myself, probably because I've not had need to, but it's very important with the length of your arms and so on that you make those adjustments. Thanks, Anne. Okay, let's see where we go here.
David?
Okay, we can use various devices, of course, to help us. This is the Kaltenborn wedge. I actually prefer the slightly bigger one myself for most things for me, which is the Evianth wedge, I understand, okay? But both of these two are very useful devices. And so when we are thinking about getting our arms around, sometimes it's totally impossible. The patient's either too big for us, we can't get around fully. So in this kind of case, it's easy enough to have the arms like this, and this might be, much more desirable for the women anyway, because you're then going to have your hand against the patient's elbow or your forearm against the elbow. I engage the correct transverse process. I let the spinous process, which belongs to that level, of course, go between here, so it'll be resting in the groove of the wedge. Now, I'm going to let him just roll a little, but now I have to keep the accommodation with that thoracic spine. I have to roll him into that position so he doesn't rest over the wedge. Then I engage the barrier by coming into the wedge, and now I will do my little movement of distraction, like, or backward glide, like that across the wedge. You see, and I think what Suzanne, you were doing, kind of moving like this to give yourself, and it's like that. You shouldn't see your head drop out like this. Okay, like that, through the body, just that little movement like this. And this, having the wedge there, it's really important that when you have done your brilliance, you let this come off and you remove it. Don't kind of great, and over the wedge, because it's very painful, and you should, the lower you get with the wedge, the more it's important to, at this area it probably wouldn't cause any great grief to sort of just let that go back like that, but if you were down, it's somewhere about T7 or T8 with a big wedge in the back, it's forcing people, and when we're dealing perhaps with spines that are getting a little more frail, we don't want to be doing that kind of thing, because fractured ribs and that kind of thing is something we don't want to happen to us. So the wedge is a useful device. Another device which is quite useful, and I see that these tables have now taken a lesson from the Canadian table, which is to use squared rods here in a square hole rather than the round rods in a round hole. Those round rods in a round hole slip. When it's a squared rod, they are much stronger. This is still not too strong because this is sort of like half there, and so you're going to have to be a bit careful. And that little bit of give probably is enough, so I can't get the spine to give, because this will give. And we know that we need everything really solid. Okay, but with having an end piece here in this upper area, could you sit up a second, Chris? The value of the wedge, of course, is that I don't have to meddle around too much on the table. With this, can you get your backside up to about here, Chris? And then I'll sort of drop him back, and he still's not quite right, so I have to go through this whole process up a little bit more here, and now come back. And I can use the edge of the table here as my contact point there, but you see this gives, and this wouldn't be sufficient to give me this rigidity on that edge. I may be able to use the other end, but I'd have to probably lift it a little bit, and we need to sort of accommodate the curve, and this does it very nicely, except it's a little bit springy. So, you know, when you look at tables, you should go and try them out, and the solider they are in these positions, and can I sit on the end without the whole thing tipping up? Those are things you should look at with tables before you actually buy one, to make sure that they're going to do for you without a lot of thinking. Oh, don't sit on this end, don't sit on that end, because sometimes, you know, when you're puzzling over a patient's thing, just sit down on there and the whole table tips up. You don't want to be thinking about that. You just want to be knowing that you can be there thinking about something and the table won't tip. I just need to have something that I think that I won't forget the patient. I've tried little things in my pockets and bells that ring and all that, but it still don't make any difference. Yeah, that's right. But sometimes keep that. I can't even keep my secretaries, right. All right, so these adaptions, and I'd like you to sort of use that wedge a little bit just as we go on, you know, further into the afternoon or further into these techniques. Just make sure you have the opportunity to use the wedge, to not let them drop back over it, to roll them onto it and accommodate the thoracic curve. And that's probably the most important thing I can tell you about these techniques, is to keep that thoracic kyphosis. Don't let it go into extension. We should be dealing with the spine in its neutral position in a sagittal plane. Now I'm going to show you how you can lock this by using non-congruent movements, and probably Diane showed you that as well, but certainly when we start using costotransverse rib mobilization and manipulation, we should be using non-congruency in the position. It stiffens the whole spine up, makes it so nice. Even with long levers, you can feel it's rigid and you can just get onto a rib. But in this area, we've got enough integral stiffness, intrinsic stiffness in this area, that we don't have to worry about all that. So here we've looked at a posterior glide technique, and we've looked at a distractive technique, and we did it by this technique, and we've done it by the wedge and the pulling, and we've used the arms also with our tripod, which is going to be basic for the whole of the thoracic spine. Now then, we should now think a little bit about how can we utilize side bend rotation in this area, and I want us to be really careful with this. There's some ghastly techniques shown here. You've had an example shown you in the line diagrams of this being done in a bad way, and hopefully we'll do it in the best way. So I'll get Chris to come on to the chair here and take a seat on the chair. Okay. And I'll get him to just slump a little bit. And just slump forward a bit. Okay, so that I can get above him. Now, what I'm talking about here is a technique of producing rotation with locking of the spine in its non-congruent position. So if I'm going to produce a rotational movement to the right, which gaps the right facets on the upper thoracic spine, I want to put the neck in a more stable position, which means I'm going to go into side flexion to the left in the presence of rotation to the right, which is the locking. Now then, in the position that you see in the line diagrams,